very important. So this study was done at primary care level. Open label cluster randomized clinical trial randomized by GP practice intervention weight management program by medical means, by dieting. Target reduce 15 kg and plus best practice by guideline. And here is control group, same number of persons, best practice care by guidelines. So initially 3006 and then 149 in control group, 149 in intervention group. Structured program in primary care setting, stop all diabetic, all hypertensive treatment. कश्तियाँ जला के आप start करो study. Then total diet replacement, या ये बड़ा precious word है, total diet replacement. For 3 months they used either soups or shakes. कोई खाना नहीं दिया गया उनको, shake दिए गए, soup दिए गए, क्यों? In order to homogenize the diet, biased न हो, किसी ने प्रोटीन ज़्यादा खा ली खाने में, किसी ने कार्बोहाइड्रेट खा ली, सबको एक जैसा रेडीमेड ब्रांडेड खाना दिया गया, शेक और सूप की शक्ल में, और मे बी सम वेजिटेबल्स थोड़ा बहुत. तो 3 months विथ 2 weekly अपॉइंटमेंट. उसके बाद आस्ता आस्ता फूड इंट्रोड्यूस किया गया फॉर 2 months, आस्ता आस्ता ग्रेजुअली. एंड देन मेंटेनेंस फेज था वेट लॉस का. वेट लॉस तो हो गया, उसको मेंटेन करें टू 24 months, 2 साल की स्टडी है ये, डायरेक्ट स्टडी. एंड 1 to 2 monthly अपॉइंटमेंट. ओके, डायरेक्ट इंटरवेंशन काउंटरवेट प्लस प्रोटोकॉल. 3 स्टेजेस थे. नंबर 1 टोटल डाइट रिप्लेसमेंट TDR, न्यूट्रिशनली कंप्लीट विथ ऑल द विटामिन मिनरल, सब उसमें सूप और शेक में शामिल किए गए. 830 कैलोरी प्रोटीन. स्टेप्ड फूड, आस्ता आस्ता फूड दिया गया, नेचुरल फूड. एंड 400 किलो कैलोरी एवरी 2 to 3 weeks. और स्टेप एक्सरसाइज बढ़ाई गई. इनिशियली 30 minutes पर डे थी और उसके बाद बढ़ाई गई. एंड वेट लॉस मेंटेनेंस, फूड बेस्ड डाइट प्लस मील रिप्लेसमेंट दोनों दिए गए, नेचुरल फूड और शेक वगैरह. अब ये रेशियो चेंज हो गया, 50% कार्बोहाइड्रेट, 35% फैट, 50% प्रोटीन. एंड आफ्टर रिलेप्स, अगर रिलेप्स हो गई तो फिर टूल किट अप्रोच, सिस्टमिक अप्रोच, या तो उसको ऑर्ली स्टेट टाइप ड्रग दी गई या ब्रीफ शुरू कर दिया गया दोबारा, टोटल डाइट रिप्लेसमेंट. नाउ काउंटर वेट प्रो 800, ये ब्रांडेड शेक्स वगैरह इस्तेमाल किए गए. अच्छा, इंक्लूजन एक्सक्लूजन क्राइटेरिया कैन नॉट गो इनटू डिटेल. किसी को GFR कम हो, हार्ट फेल्यूर हो, कैंसर हो, मायोकार्डियल इंफार्क्शन हो. अच्छा, दीज आर द रिजल्ट्स. नाउ ये रिडक्शन इन द बॉडी वेट सक्सेसफुल, बट ये ड्रॉप आउट्स हैं. ड्रॉप आउट जिसने किया वो वापस वेट गेन, अदरवाइज सस्टेन्ड फॉर 2 years. अच्छा, एम क्या थे? 2 को प्राइमरी आउटकम थी ये अचीव करना, लेस देन 15 kg बॉडी वेट. और सेकंड था रिमिशन ऑफ द डायबिटीज, वजन तो कम हुआ, शुगर खत्म हुई या नहीं हुई. सेकंड. ओके, सो पी वैल्यू सक्सेसफुल 24%, 1 quarter जो है उसने अचीव कर लिया फर्स्ट ईयर में. और यहाँ पे अब अबाउट 50% ने रिमिशन अचीव की 15 किलोग्राम लूज करने के बाद. अच्छा, अगर हम 15 की जगह 10 किलोग्राम लेके आए तो 73% ने रिमिशन अचीव की. सेम फिगर जो बेरियाट्रिक सर्जरी में हमने देखी, सेम रिजल्ट विदाउट सर्जरी. Okay, diabetes remission at 12 and 24 weeks, 46% first week and 36% first year, second year. और कंट्रोल ग्रुप में only 43%, और यहाँ देखें 46 और 36%. P value very significant. और सेकेंडरी बेनिफिट HbA1c, एंटी डायबिटिक मेडिकेशन रिड्यूस्ड, एंटी हाइपरटेंशन मेडिसिन रिड्यूस्ड, ट्राइग्लिसराइड क्वालिटी ऑफ लाइफ इंप्रूव्ड, ऑल स्टेटिस्टिकली सिग्निफिकेंट. ओके, बीपी फॉल, सिस्टोलिक बीपी भी ड्रॉप हो गया बाय दिस डाइट रेजिमेन. क्वालिटी ऑफ लाइफ इंप्रूव्ड. नाउ डायरेक्ट स्टडी कंडक्टेड इन रियल वर्ल्ड प्राइमरी केयर सेटिंग, आई रिपीट. एंड नो एक्स्ट्रा क्लिनिकल स्टाफ वाज नीडेड, कोई ज़्यादा खर्चा नहीं हुआ, वही जो एग्जिस्टिंग स्टाफ है वही कंटिन्यू था, बट नीड स्टाफ ट्रेनिंग, 8 महीने उनको ट्रेनिंग दी गई स्टाफ को एंड सपोर्ट, एंड लिमिटेड टू यूके पॉपुलेशन, जिस तरह यूके पीडीएस स्टडी थी ऑन इन यूके, ये भी यूके में था. सो वी नीड दिस टाइप ऑफ ट्रायल इन पाकिस्तान. So direct study, this is the last slide about direct study. Around 10%, अब problem ये है कि 90% obese हैं, 10% they have got type 2 diabetes but they are not obese. उनका क्या होगा? तो एक और स्टडी आ गई, उसका नाम था रीट्यून स्टडी. ये जो सेकंड ऑथर था रे टेलर न्यूकैसल का, उसने ये स्टडी की. अच्छा, ही वॉज अपॉइंटेड एज डायरेक्टर ऑफ इमेजिंग सेंटर जो न्यूकैसल में था, MRI मशीन वगैरह का इंचार्ज बना दिया इसको. तो वहाँ पे एक लेटेस्ट MRI मशीन आई जो पेनक्रियाटिक फैट कैलकुलेट करती थी क्वांटिटेटिव. देन ही डिड स्टडी, और एक नया ब्रेक थ्रू आ गया कि नाउ इट इज वी यूज द टर्म फैटी लिवर. अब फ्यूचर में आप सुनेंगे फैटी पेनक्रियाज, फैटी पेनक्रियाज. सो लेट अस सी, around 10% of people with type 2 diabetes have BMI that puts them in healthy range. They are normal, less than 27 according to their criteria. BMI. However, people with lower BMI may still store internal fat in pancreas and liver. बाहर से नहीं है, अंदर. Could be one of the reason that they develop type 2 diabetes. So, RETUNE study testing if people with a BMI less than 27 can lose internal body fat in the liver and pancreas and go into remission with the same regimen, diet same. अच्छा, Professor Ray Taylor and his team studied whether a low-calorie diet can help these non-obese patients with diabetes to put their condition into remission. So again 75%. You remember the figure. उसमें भी डायरेक्ट में भी 73, 75, यहाँ भी 75, बेरियाट्रिक सर्जरी में भी 75. रिजल्ट ऑफ रीट्यून स्टडी, द प्लान डिक्रीज इन बॉडी वेट 8 किलो, उस पर भी कम हुआ, वॉट एवर बॉडी वेट वॉज देयर. टोटल बॉडी फैट, fasting blood sugar, HbA1c, fasting plasma level, triglyceride, liver fat, pancreas cell, all improved. P value significant. So direct और उसमें फर्क क्या है? ये 27 से ज़्यादा, ये less than 27, और मैयट लिवर एंड पेनक्रियाटिक फैट. अब ये रिजल्ट जो आ गए, इसमें ये है लिवर का फैट और VLDL, ट्राइग्लिसराइड बोथ इम्प्रूव्ड. और यहाँ पे फर्स्ट फेज इंसुलिन, बीटा सेल फंक्शन और पेनक्रियाटिक फैट सेल ऑल आर इम्प्रूव्ड. सो लिवर फैट बिफोर एंड आफ्टर वेट लॉस स्टेटिस्टिकली सिग्निफिकेंट. सेम थिंग अब स्टेटिस्टिकली बता रहे हैं. पेनक्रियाटिक फैट आल्सो इम्प्रूव्ड इन बोथ डायरेक्ट एंड रीट्यून. बोथ, चाहे वजन ज्यादा हो चाहे कम हो, दोनों में पेनक्रियाटिक फैट, लिवर फैट कम हो गया ड्यू टू दिस डाइटिंग. सो इफेक्ट ऑफ वेट लॉस, चाहे 5 किलो कम करें फिर भी बेनिफिट है, 10 किलो कम करें, 10% सॉरी, तो और ज्यादा बेनिफिट हैं. यू सी द बेनिफिट्स. 10 to 15% और ज्यादा बेनिफिट हैं, और मोर देन 15% पे रिमिशन आ गई अलॉन्ग विद अदर बेनिफिट्स. सो 15 kg इंटरनेशनल वेज, ये सबसे ज्यादा इंपॉर्टेंट स्लाइड है मेरी. यू सी 50 kg इंटेंशनल वेट लॉस माइट नॉर्मलाइज द लाइफ एक्सपेक्टेंसी. वो 5-6 साल जो लूज कर रहे थे वो वापस आ गए. ये देखें, लाइफ एक्सपेक्टेंसी इंप्रूव्ड. ये पहली स्लाइड में दिखा रहा हूं कि 5-6 साल कम हो गए थे. अच्छा, ये लास्ट 2-3 स्लाइड्स हैं. क्राइटेरिया फॉर रिमिशन, ये कंसेंसस है कि HbA1c 6.5 से कम हो, फास्टिंग ब्लड शुगर 100 से कम हो 1 साल तक, तो हम कहते हैं कि रिमिशन. ये है मेडिकल बेनिफिट. रिमिशन के मेडिकल बेनिफिट क्या है? रिमूव नीड ऑफ द लाइफ लॉन्ग मल्टीपल ड्रग थेरापी. कोई दवाई न लें आप, नो ट्रीटमेंट for at least for diabetes. Other cardiovascular risk, blood pressure, lipid improve or normalize, reducing the need of those tablets as well, or complication for these conditions. Multi-system improvement in health and quality of life. अब यहाँ देखिए, value of appropriate coding of patients, epidemiological and healthcare planning, remove personal and social stigma. ये तो diabetic है, ये तो diseased है, no stigma, है ही नहीं diabetes, खत्म for many years. Provides a target and reward for the sustained hard work. आपने हार्ड वर्क किया, डाइटिंग की, अब उसका रिवार्ड ये है कि डायबिटीज खत्म फॉर मेनी ईयर्स. अभी तक 2 साल की स्टडी है. अवॉइड हाई कॉस्ट एवरी लेवल. भाई डायबिटीज से नहीं है तो डॉक्टर के पास क्यों जाएं? दवा क्यों लें, इन्वेस्टिगेशन क्यों कराएं, lot of cost benefits. Remove some occupational restriction. Heavy machine नहीं चला सकते आप due to hypoglycemia fever. पायलट जहाज नहीं उड़ा सकते, अब जहाज उड़ाएं, आपको शुगर है ही नहीं, रिज्यूम, कोई ग्राउंडिंग नहीं है पायलट की. Identify a valuable indicator of success in healthcare through National Disease Register monitoring. So conclusion and actions. Remission should now be a primary aim of diabetes care. अब इस पे फोकस करना चाहिए remission पे. Almost half can achieve remission, 73% if more than 20. So 73 का हम याद रखें. Over 15 kg loss is rarely necessary. ज़्यादा जज्बाती होने की ज़रूरत नहीं है. 15 kg से ज़्यादा करेंगे तो कोई फ़ायदा नहीं होगा, may be harmful. Offer optimal non-surgical weight management early before prescribing additional drug. Sugar control नहीं है, और दवाएं दो, और दवाएं दो, और दवाएं दो, with a lot of side effects. अब डाइटिंग कराएं उनको. And long before considering bariatric surgery. Now, is it possible to achieve same result? This is my question. Is it possible to achieve same result without bariatric surgery by physicians, not by surgeon? If yes, then what bariatric surgeons will do in future? Yawning, and thank you. So question answer will be at the end of the session. अभी कराते हैं? अच्छा आइए. ओके. शबनम तांचो. आइए प्लीज. ओके, एनी क्वेश्चन? माइक.
Thank you very much.
हाँ प्रताप यू मौसम जो मैंने
Thank you, Zuman Sahab. Thank you, Zuman Sahab, for a very good initiative. अल्लाह ताला आपको कामयाब करे. मेरे चंद को सवालात हैं कि देखें, जब आप बॉडी इंटेंसिफाई का रेजिमेंट लाते हैं फॉर वेट रिडक्शन, तो हमारी क्योंकि वेट रिडक्शन मेनली होनी है सेंट्रल, हम पाकिस्तानी सेंट्रल ओबेसिटी, लोटल ओबेसिटी है, बाकी यहाँ वेस्टर्न वर्ल्ड में तो ग्लोबेसिटी है. ठीक है, हमने कहा कि अगर 10% बॉडी वेट रिड्यूस करें तो आप एटलीस्ट 20 to 30% फ्रॉम लिवर लूज करते हैं. द फर्स्ट थिंग दैट बेनिफिट्स व्हेन यू आर रिड्यूसिंग वेट इज योर लिवर, कि लिवर की जो, और लिवर की वजह से ही तो इंसुलिन रेजिस्टेंस होता है. पेरिफेरल तो इंसुलिन रेजिस्टेंस नहीं करते फैट सेल्स. तो इसमें आपके जो हुआ, जो आपने स्टडीज प्रेजेंट की, जो सक्सेस स्टोरीज थी, दे वे नॉट वेरी
be a speaker in this important conference, the Karachi International Conference, and I'm going to talk about type 2 diabetes in the young. According to the Center of Disease Control, 1 in 3 children born in the US in 2000 will become diabetic in the future, and mostly type 2 diabetes. Is it an epidemic or not? Incidence of type 2 in the youth is increasing and probably underestimated, and the population-based estimates indicate that there is 10-fold increase in the incidence of type 2 diabetes in the youth and young adults over the past 10 to 15 years. Type 2 diabetes in the youth before 1990, only 5% of children or adolescents were diagnosed with diabetes type 2 diabetes. Now they account for 30 to 50% of new cases of diabetes in the youth, and the increasing incidence of type 2 diabetes in the youth parallels the national data estimating a triple in the rate of overweight in adolescents in the past 20 years. And it is considered the first consequence of the epidemic of obesity. There is a changing face of type 2 diabetes in the youth in US, and according to this study done between 1987 and 1996, there is increasing incidence of type 2 diabetes in different US states. These are the risk factors for type 2 diabetes in the youth and young adults. There is non-modifiable risk factors for youth onset type 2 diabetes in the form of genetics or epigenetics, a strong family history of type 2 diabetes in the first or second degree relative, or being an offspring of a pregnancy complicated by gestational diabetes and possibly an obese mother, minority race, insulin resistance of puberty, and genetic susceptibility detected in the first decade of life, manifested as impaired insulin sensitivity, reduced insulin secretion in an otherwise healthy young with a family history of type 2 diabetes. This genetic susceptibility, when combined with environmental factors, lead to obesity and sedentary lifestyle, may ultimately translate to type 2 diabetes. In a study of youth with obesity, a genetic risk score of beta cell dysfunction from 5 single nucleotide polymorphism was associated with higher chance of prediabetes and type 2 diabetes in the youth. There's dozens of specific genetic variants linked to type 2 diabetes. In the youth onset type 2 diabetes, there is major modifiable risk factors in the form of obesity, excess nutritional intake, low physical activity, increased sedentary behavior and lifestyle, decreased energy expenditure, and other potentially modifiable risk factors include chronic stresses and or depression, mood, and sleep-related disorders. Currently, 25 of obese children are pre-diabetic, and if we do nothing, 35% of children born in 2003 will develop diabetes in the future, and those with diabetes will lose an average of 13 years of their life. This is a study showing overweight and obesity among school children between 5 and 17 years old in different places of the world, and this is the prevalence of overweight and the prevalence of obesity and maximum in the Americans. This is another study showing the enrollment in daily physical education classes between 1991, showing reduction in the exercise hours in 1995. Children are becoming more sedentary with less physical exercise in the school, more screen time, and only 50% get regular physical activity, and 14% of the teenage children or adolescents report no physical activity at all. We come now to an important question: what distinguishes type 1 from type 2 diabetes in the youth? And pediatric diabetes is a difficult diagnostic specialty. This is the childhood obesity. Some overlap with type 1 diabetes in the young. They are mostly average weight or underweight, but some of these type 1 diabetics may be obese. But type 2 diabetes in childhood and adolescents, they are mostly obese. Monogenic diabetes, diabetes with some genetic syndromes. And this table shows the differences between type 1 and type 2 diabetes. In type 1 diabetes, 20% of them may be obese, and in type 2 diabetes, more than 85% are overweight. And the course in type 1 is rapid, but in type 2, it's indolent, with no symptoms mostly. The diabetic ketoacidosis occurs in 35 to 40% of type 1 diabetics, while there is mild ketonuria and DKA in 5 to 25% of type 2 diabetics in the young. A relative with diabetes, we can find 5% with type 1 diabetes in those with type 1 diabetes in childhood or adolescence, and up to 20% may have history of type 2 diabetes, while in type 2 diabetics, 74 to 100% are having a relative with type 2 diabetes. Comorbidity in type 1 diabetes, thyroid disease, adrenal disease, vitiligo or celiac disease. And in type 2 diabetes, there is increase in the polycystic ovary syndrome in girls and acanthosis nigricans in both girls and boys. The C-peptide can be preserved at the diagnosis of type 1 diabetes, but it's normal or increased in type 2 diabetes, and the presence of antibodies in type 1 diabetes happens in up to 85%, but they can also be present in 15% of type 2 diabetics in the young. Another question. The presentation, is it asymptomatic or symptomatic? And the study showed that the mean age for type 2 diabetes in the young is 12 to 14 years, and girls to boys ratio is 1.7 to 1. It's more prevalent in girls, and obesity and body mass index happens in more than 95th percentile, and the minority groups 94%, strong family history in 74 to 100%, acanthosis nigricans in 56 to 92%. And diagnosis can be made with symptoms, not screening, because hemoglobin A1C was between 10 to 13%. Weight loss happened in a certain percentage of the patients. with ketosis in 16 to 79% in different meta-analysis, and DKA in 5 to 10% of the cases. This is a picture of the acanthosis nigricans. And according to the American Diabetes Association, when 21 went to screen for type 2 diabetes or pre-diabetes in asymptomatic children and adolescents in the clinical setting, in overweight more than 85th percentile or obese more than 95th percentile, who have one or more additional risk factor in the form of maternal history of diabetes or gestational diabetes, family history of type 2 diabetes in the first or second degree relative, race or ethnicity, signs of insulin resistance conditions in the form of acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary syndrome, or small for gestational age plus weight. Another important question, what are the treatment targets in use with type 2 diabetes? Are they the same as in adults or not? And according to ADA 2021, the pharmacological therapy and behavior counseling should be initiated for healthy nutrition and physical activity at the diagnosis of type 2 diabetes. In incidentally diagnosed or metabolically stable children with hemoglobin A1C less than 8.5 and they are asymptomatic, metformin is the initial pharmacological treatment of choice if renal function is normal. In use with marked hyperglycemia with blood glucose more than 250 milligram or hemoglobin A1C more than 8.5% without acidosis at the diagnosis, and they are symptomatic with polyuria, polydipsia, nocturna, or weight loss, they should be treated initially with basal insulin together with metformin. In patients with ketosis or ketoacidosis, the treatment should be with subcutaneous or intravenous insulin initiated to rapidly correct the hyperglycemia and the metabolic acidosis. And once acidosis is resolved, metformin should be initiated while subcutaneous insulin therapy is continued. In individuals presenting with severe hyperglycemia with blood glucose more than 600 milligram per deciliter, consider assessment of hyperglycemic hyperesmolar non-ketotic coma. If the glycemic targets are not met with metformin with or without basal insulin, liraglutide is approved therapy and should be considered in children 10 years of age or older with no past medical history or family history of medullary thyroid carcinoma or multiple endocrine neoplasm type 2. And this is the figure for management of new onset diabetes in the youth with overweight or obesity according to the hemoglobin A1C and the presence of symptoms and the presence of diabetic ketoacidosis or hyperosmolar non-ketotic diabetic coma. And we should check the pancreatic antibodies if positive or negative, and if positive, continue or initiate multiple daily injection of insulin or pump therapy as for type 1 diabetes and discontinue metformin. But if negative, continue or start metformin, and if on insulin, titrate guided by SMBG, and if goals are not met, continue metformin, consider adding liraglutide and titrate insulin if using basal insulin only or to give Vangel insulin. Metformin improves the glycemia in type 2 diabetes in the adolescents, and this study was a double-blind study and showed the importance of adding metformin to type 2 diabetes in the adolescents. Metformin is well tolerated, but some may complain of abdominal pains in 25% of cases and diarrhea in 17% of cases, but no treatment withdrawal for the drug-related gastrointestinal side effects was found. Another question: what are the associated risk factors in use with type 2 diabetes? There is specific lipid and blood pressure abnormality in children with type 2 diabetes. The lipids, same as adults, increased triglycerides, slight elevation of LDL and decreased HDL, and the blood pressure 3.4% systolic blood pressure increase more than 95th percentile, and 20% diastolic increased more than the 97th percentile. The question now: how can we stop this diabetes epidemic in the youth and children and young adults? Lifestyle management, according to the ADA, is very crucial. At least 60 minutes of moderate to vigorous physical activity daily with muscle and bone strength training at least 3 days per week, and healthy eating patterns. And according to the International Diabetes Federation recommendation for healthy diet for general population, and to choose water, coffee, or tea instead of fruit juice or soda drinks or other sugar-sweetened beverages, to eat at least 3 servings of vegetables every day, including green leafy vegetables, and eating up to 3 servings of fresh fruits every day, choosing nuts, pieces of fresh fruit, or yogurt for snack, to limit alcohol intake to maximum, and to choose lean cuts of white meat, poultry, or seafood instead of red meat or processed meat, to choose peanut butter instead of chocolate, and to choose the whole grain bread, brown rice, or whole grain pasta instead of white bread, rice, or pasta, and to choose unsaturated fat like olive oil, canola oil, corn oil, or sunflower oil instead of saturated fats like butter, animal fat, coconut oil, or palm oil. This is again the WHO recommendation for physical activity in different age groups, and for children and youth age 5 to 17 years should do at least 60 minutes of moderate to vigorous intensity physical activity daily. Type 2 diabetes in the youth and children is a team approach between endocrinologists, physicians, general practitioners, diabetes educators, dietitians, student himself and family, and school and media. How do you initiate a change? School can provide quality daily physical activity classes, nutrition awareness campaign, parent education awareness campaign, psychological education and psychological intervention, school nutritional policy, and the main message: patients are important influence on their children's eating and activity habits. And again, the main message: change takes time, begin by taking a few small steps. Thank you. Thank you very much for inviting.
Thank you, Professor Nas, for this informative talk. As we are short of time, so we will take 2 to 3 questions from the audience, and one of the speaker, Dr. Zaman Sheikh, is available over here. So we will take 2 2 or 3 questions from the audience. If you are having any question, please raise your hand so we can reach you.
Thank you so much. I think a wonderful talk on a very ill-understood problem in pediatrics in Pakistan, the diabetes. Yeah, we will request the panel. Najam is there. I'm sure he can. She very elegantly highlighted. The first thing is that in this conference, as you can see, in any of the halls, there will be no branding of any by pharmaceutical. See around your hall, there is no drug involved. So we are following the GCP, Good Clinical Practice Guidelines. So, and in the halls, we will not allowing to distribute any literature related to brand names at all. It's only an education material. And number 2, all the speakers, they must disclose the conflict of right in the first slide. So we have requested repeatedly to all speakers to do that. This is a wonderful talk. I really enjoyed it. Najam perhaps can, she in the algorithm that she said, treating type 1 diabetes, insulin of course is the mainstay of, but now we are increasingly using, I know FDA has not approved it, but from my point of view, I'm increasingly using GLP-1 receptor agonist. The reason of, obviously they will not do much to the beta cells which are not there in the pancreas, so glucose mediated beta cell release will not be increased, but they have another very important aspect, GLP-1, of suppressing the glucagon, and for that reason we use it. Also in the algorithm, I think now ADA has come up and they are using it in the algorithm, evidence-based thing, that SGLT2 they can easily be used in type 1 diabetes, so that the requirement of insulin decreases and also the surges decreases. So I think this is these algorithms are a little late, but now we have another thing. Jaida and myself are doing work on monogenic diabetes in Pakistan, and in monogenic diabetes, obviously it's a whole syndrome. So we are trying to define a panel which we will be having patented from US FDA, that any child can, be tested through that panel and tell us exactly that what type of diabetes is there, just like Mohan did in India. So we, Jaida and myself, Jaida is here from Children's Hospital, we are already doing, we think there are few mutations. Mutation of short arm with 7 to 11 mainly defines that it is it is not type 1, it is type 2 diabetes with certain features. So maybe one of you can develop GLT2 1 diabetes, GLP-1 receptor agonist used in type 1 diabetes, and then this classifying in our community, because it may not be have our own different mutations.
Thank you, Professor Javed Akram, for your input. Now I will proceed with our respected chairpersons for the comments so we can successfully conclude the session. Dr. Bikaram, Dr. Najmul Islam, and Dr. Zainab.
Assalamu alaikum everybody, and I would like to thank Pakistan Society of Internal Medicine for inviting me to chair this session on diabetes. There were 2 excellent lectures on the topic which is relatively novel in that sense, that one is for the cure of diabetes by Professor Zaman Sheikh, and the other is on type 2 diabetes in the young. When I was a medical student, we never used to hear about type 2 diabetes in young, but for the last 2 decades we have been hearing about this disease, particularly in adolescents. So this is something that our juniors should know about and be ready to manage them in the future, because type 2 diabetes in young will increase every day. Particularly, there was a data from Japan about 15-20 years ago in which 60 to 80% of the diabetes in adolescents was type 2 diabetes. So it's not just a phenomena restricted to the West, it is also something which is happening in the other parts of the world, including the developing world. So type 2 diabetes in young is a very important topic to know. And as an answer to Professor Akram's remark about the algorithm and the use of other drugs in type 1 diabetes, obviously at the moment the evidence is not that strong, so that's why there have been very selective recommendations for using SGLT2 in type 1 diabetics and also the GLP-1 receptor agonist. SGLT2, the European Medical Associations have recommended that to use type 1 diabetes in who have got a BMI of more than 27, SGLT2 inhibitors. So, but remember one thing, particularly for the juniors, that they should not be using this in isolation, and they should be used along with insulin, and also not by everybody, but by the specialist, because there is an issue of increased diabetic ketoacidosis in type 1 diabetes by using SGLT2. So this is something which has to be used very cautiously and very selectively. So and about the monogenic diabetes, obviously in Pakistan we are not able to make a diagnosis of monogenic diabetes, and most of them are being treated as either type 1 or type 2 diabetes without knowing that they have got monogenic diabetes. And for that we have been sending pediatric endocrinologists have been sending samples to Exeter to make a genetic test. And I think if Professor Akram is coming up with a genetic testing facility, that would be an excellent thing, and we can send our patients samples of the patients for making a diagnosis of monogenic diabetes, which is unrecognized in Pakistan, knowing, because there are so many types of monogenic diabetes. I think presently there are 12 types of monogenic diabetes. So every day the numbers are increasing. So obviously for that a genetic panel is required. So I think these things will happen. And about the Dr. Zaman Sheikh's study, those two important studies that he has shown, that weight reduction leads to cure of diabetes. That is something that is a very important aspect. But this has to be replicated in the developed world and also in this part of the world, so that see if this same thing happens in this part as well, both in those who are obese and both those who are non-obese, and the cutoffs are different for this part of the world. So these are the comments that I had to make about these two talks, and I would like to congratulate both the speakers for their excellent
Thank you, Dr.
lecture.
Thank you, Professor Najmul Islam. I will request Professor Bikaram for the comments, please.
First of all, thank you very much to give the opportunity to talk over here. We are proud of Pakistan Society of Internal Medicine that we are not only discussing the internal medicine, but we are discussing all the medical problems as a whole. And regarding the diabetes, today's both topics were very interesting, and particularly the diabetes in young. Previously, we were knowing about that there's a Modi maturity onset diabetes of young, type 1, 2, 3, 4, 5. And now the diagnosis of diabetes type 1 age is usually from 10 to 14 years. And in children, type 1 is usually diagnosed as from 10 to 14 years, the average age previous studies shows. Now I think here we can categorize that thin, lean boy having the diabetes, signs of diabetes, and another obese and hence having the signs of diabetes with the same age group, 10 to 14 years, then we must investigate those children and then categorize them whether they are type 1 or they are diabetes in young. If they are obese and having the particularly we are interested in the female having the polycystic ovary syndrome, and are the young girls, they have been married after the age of 18 years, they have developed the diabetes in pregnancy, then we must investigate those married lady. And I am rightly said by the Professor Javed Akram Saab, the GLP-1 receptor agonist along with metformin is good, because if we know if insulin sugar is high and if we are not using the insulin, even in type 2, the diabetes in young patient may develop the non-ketotic or hyperosmolar coma, and the attitude and knowledge of the children, they can go into the coma, and that will be very dangerous. And I think there's a growth of the growing age of the children, then we must be careful about regarding their proper growth. And body weight is ideal, but unfortunately in our nowadays setting in cities, in towns, the pizza and KFC and burgers, and I have conducted a survey in schools that how many children they eat the vegetables, and unfortunately they are not using the vegetable, they are always using the chicken, even not the meat. So this behavior we have to change, and we have to make some our own concrete guidelines to disseminate this knowledge into the schools in the children, otherwise they will become, diabetes will increase. And last week I was sitting with the Minister of Education province of Sindh. We were talking about regarding the diabetes and hypertension. Then we concluded that we must give at least basic knowledge to the teachers and to the students and to the parents. This is the high time we have to. So I think Pakistan Society of Internal Medicine should take the lead of this. Another thing, the very good idea of Professor Javed Akram Saab, he has involved the pediatrician. Now the pediatrician has to play the role. Of course, general physician or a general practitioner, they are treating all the patients. They should be the key person to have a research and to categorize these patients and to for the proper referral. Thank you very much. I congratulate the organizers of this conference, Professor Aftab Mohsen, the Professor Azizur Rahmani, who is the chair of scientific program, and he was trying to accommodate the farmash of everybody, and really I salute you. Thank you, sir. Thank you.
Thank you, Professor Bikaram. I will request Professor Zainab for a few comments.
Assalamu alaikum, everybody. So I'm going to try and keep my comments a little brief here. I think I want to make 3 points. The first is that, we're sitting here, and I'd like to say that we're sitting here post-pandemic, and it's great to be able to see people in person finally in conferences. But post-pandemic also means, in terms of children, the fact that over the last 2 years, a lot of schools have actually been doing online schooling, right? A lot of our children actually get their physical activity in their school time. They go, they walk into class, they get their PE. And kids have been sitting at home, they've been gaining weight, and they've not been physically active. So the second lecture I thought was very spot on, in the sense that we'll probably be seeing a slew of adolescents landing in the spectrum of diabetes in Pakistan post-pandemic, and in the milieu of very strong family histories of diabetes, just given the prevalence that we've got on our hands right now. That's one. The second point is Dr. Zaman Sheikh's lecture, I always really enjoy them because they're so educational and very, very to the point, was the fact that, diet is a really important diet with the goal of weight loss, not diet with the goal of blood sugar optimization. The diet with the goal of weight loss is a really key tool in getting people to have remission in diabetes. When I'm a cardiologist, I see patients on their way out in the funnel of how diabetes go in terms of complications. When the patients walk into my clinic, they often don't know that the diet advice that they got was actually not for just blood sugar optimization, it was actually to induce weight loss. And that's something we really need to make sure that the patients understand. Bhai, aapko 15% वजन कम करना है. with whatever dietary changes we are recommending. So that's something really to make a point with our diabetes educators, with our internists, and all who are dealing firsthand. The third point is, I've been really, so thank you very much. And I would like to add that it's been a real honor to share the stage with my teacher, Professor Najmul Islam. He taught me when I was a third-year medical student. I remember doing clinics with him. So a real honor, and thank you for inviting me.
So at the end of the session, I will thank the President, Vice President, Chairpersons, and speakers for such a nice session on the diabetes update. And the end, I will say that diabetes is reversible, as Dr. Professor Zaman Sheikh said, and that is a good news. And diabetes in a young is a major issue, and how we will have to fight with this major